miss you all. It makes me feel good when I see you here and turn up to this unique club that we all belong to. Didn't, right? So I want to just say it's been a really tough week with the elections and all, and that it's been a really tough month here in Santa Cruz with the death of Sean Arlt. And fear is a great and powerful cloud that I have been feeling, and I know you have too. So I want to remind us to be strong, because if there's anything that NAMI families understand and have learned, it's how to stay strong, how to be strong. I think it's fitting that tonight we pause a minute to remember this remarkable young man and father who 1 month ago tonight left us, and we uniquely understand our community. We get this, how this could be any one of us or someone that we know or love. So I was really grateful that Michael Fitzgerald, who's going to be our speaker tonight, suggested that we change the tone and the topic for tonight, that we start to get serious to learn what do we do to change and improve our mental health systems, our relationships with law enforcement. How do we get to the bottom of why it works so poorly? And he is uniquely qualified to speak about this as the director of the El Camino Hospital's Behavioral Health Center, and also on the California Hospital Association. So, times are changing. We've got parity, right? When is that going to kick in? Insurance is going to pay for mental health services. There's opportunities for new providers to make money doing new things. And what's going to be different in 5 years, and how are we going to write the story that we want to see happen? What about our relationship with law enforcement? How do we ever regain our trust in calling 911? What are we going to do to assure that this never happens again? NAMI is advocating for the most thorough and honest review of the trainings, the protocols, the policies, and the police and the city council are meeting with us. The strongest and the most productive thing that I see at the moment is deep and meaningful education for law enforcement. And I'm really pleased that we have this already scheduled training beginning in February. If you want to be a part of this with your storytelling, we'll be training ourselves to be very powerful speakers on December 17th right here in this room. So let me know, join us, because we want a team of about 20, 30 people who can rotate responsibilities with different law enforcement venues to help them know the human face, who we are, who our family members are, and help officers have full compassion so that they stop and think before they act. So, now to introduce Michael. I'm very grateful that Michael is here. I think this discussion is important. His role in the whole state of California is shaping what hospitals are doing, and his deep experience as a provider and as a NAMI member here in Santa Cruz, and as all of his work at El Camino Hospital. We're just honored and grateful to have you here. Please join us, Michael.
I'll try to speak without this, and let me know if it's I don't need help. Yeah. So a couple of things about my speaking style you should know. I talk fast, passionate. I ramble sometimes a bit. So any questions, kind of think, okay, boy, that didn't make a lot of sense. Grab me. I get passionate sometimes. I come from a family of criers, so every once in a while, that might come up, and just give me a moment. I'll be fine. I'll start it again. It doesn't incapacitate me. The moment will pass. I'd like to point out my biggest distraction is my beautiful great niece over there. My niece is over there. And what I'd like to do also is introduce our community liaison specialist. Lauren, would you stand and turn so they can see you? Lauren is lives here in Santa Cruz. I live in the county, have almost my whole life, still do. And Lauren's our connectivity with the communities, with the NAMI, with all organizations in Santa Clara County, which is where we're based. But she and I are, this community she grew up here as well, near and dear to our hearts. So we're looking all the time to see what we can do to help affect the systems and services here in Santa Cruz, where I began my mental health career, much younger, many decades ago now, but have been in this my whole life and many years here in Santa Cruz as a provider at every level. My last clinical position was a clinical specialist psychiatry, and so I'm a nurse psychotherapist and had private practices, worked in psychiatric emergency rooms here in Santa Cruz. And I got into management and administration unwillingly, really. I did it because I felt like somebody had to do this, right? I mean, I felt like some of the policy decisions, procedural decisions were affecting the way that I did my work in the emergency room. Patients we admit didn't stay long anymore. They used to. Some people we used to admit didn't admit at all anymore. And there just seemed to be a change gradually. The funding streams has set a cause. I'll go into that in a minute. But anyway, that encouraged me to say, well, okay, you can complain about it. And my wife certainly heard plenty of my complaints, or you can do something about it. And so I ended up getting into administration management. Today I'm the executive director at El Camino Hospital, and so oversee behavioral health services there. We've got lots of outpatient programs. We started a program, only one of its kind in the country, for perinatal moms. It's an intensive outpatient program. They bring their babies to groups. It's wonderfully supported by the community of donors. And then we have our youth programs, Aspire, which stands for After School Program Intervention, something like that, resiliency education. But it's known as Aspire, and so we have that from the middle school all the way through transitional age use, so different programs in Los Gatos, a couple in Los Gatos, a couple in Mountain View at our campuses, both sites. So we treat a lot of kids from Santa Cruz in our Los Gatos site, and we would like someday to be able to bring this program. Lauren and I very much like to bring this program to Santa Cruz, but it will take partnership with Sutter or Dignity or somebody, because that's the only way that would work for us to be here. Oh, we'd love to do it, yeah. We've got thought disorder programs. One of the things about mental health that you learn is that you can't take a whole bunch of mental health patients, okay, I got symptoms, and put them in a group and say, here you are, because it is not, monolithic, right? It is all range of people with various conditions, and they're not the same thing anymore. An orthopedic injury is the same thing, right? I mean, what do? You get surgery, the same surgery for knee surgery, well, maybe their ankle, et cetera. That's kind of how it is for mental health. That's how I'd like to think about it. And so we've got thought disorder program, mostly treats young adults, early intervention for psychosis symptoms, and then we have mood disorder programs. We have a DBT track to introduce them to the DBT systems in the community, and we've got older adult services. We've got an addiction program. We've got a dual diagnosis program. So lots of different programs that we have, and it's not the most cost-effective way. We've got a consultant that kind of help us get better financially. First thing he says, well, what are you doing all these specialty groups? You have to mix them together and more efficient. And we said, well, thank you very much, but that's a no for us. Let's go on to something else we can do. So the community has really responded to that. We're creating systems of care where the people, the donor community feel like, okay, my family was touched by that, and they've got a place to there's a lot of money in Silicon Valley. We've tapped into some of that. We raised $6.5 million in 2 years. We thought we'd get $5 million in 5, so we were very pleased, and we're still raising money. We've got a very dedicated group of people. Big news, a couple weeks ago we broke ground for what's going to be a 52,000 square feet and probably $60 million new behavioral health building. No one's doing this, hospital-based. It'll be 36 beds, all private. We build it kind of like a hotel. I mean, this is really expensive, but our board is very committed to this population. If you ask any of the board members, well, you're not a profit hospital, what do you do for the community? Mental health will be the first thing that they talk about. It's really a commitment from the board. Very, very appreciative. We're very lucky to be there. Now, talk a little bit about what I've done at the state level. I'm the current chair for the California Hospital Association Behavioral Health Center. So I represent all the hospitals in the state, all the psychiatric units in the state, private facilities, everybody who's a member of that, and almost every place says it's a hospital. So I chair that group. It's my third year and final year as chair, and then I'll step into a past chair role. My focus in that has been to talk about system delivery and system change. I worked hard unsuccessfully on a piece of legislation that would have changed some of the commitment laws in California, not in a severe way in terms of keeping people who didn't want to be in the hospital and didn't need to be, but more about how do we get people access and services, and because that's challenging, and I don't even need to go into that with this audience. You've all had, I'm sure, experiences with the mental health delivery system. We were unsuccessful in getting that passed. We're going to try a different approach where we're going to really work partnership with California NAMI at the state level, local NAMI organizations, and other people, and try to, rather than the hospital sort of leading this charge, we're going to try to get other people to lead it who may be not seen as lobbyists or protecting self-interest, because hospitals don't have the greatest reputation in the world sometimes for behavioral health care. So how do we get to the system that we're in? I'm going to talk about that for a while, and the thing I won't talk about is the shooting death of a mental health client here in Santa Cruz, because, you know, as I say, I wasn't there, no video. One thing I know about Santa Cruz is they will demand transparency. This population will not accept anything but a full review, full transparency. It won't happen. I mean, they're going to do that. They have to do that. The community will demand it. So what I'd like to talk about is, how is there a system of care that is developed to where somebody with those significant symptoms could be in a situation where just 5 days earlier, you know, he was tased by police, difficult time taking him down, brought him to the hospital. 5 days later, he's there and he's killed. And so you wonder, what kind of system did this come to? Now, first thing I want to say, well, let me say, first thing is, they're doing some amazing things in Santa Cruz County. Just tonight, I touched base with people that I've met, people I knew, and Santa Cruz County is doing a lot of things for people with, you know, significant mental health conditions, with integrating in the community, with peer groups, with housing support at times, with going, my nephew-in-law, is that the right term, Patrick? He's with MHCAN. He's just talked about the things he's doing. You can see the excitement in his face and the reward he gets from what he's doing. So Santa Cruz is doing amazing things. So we're very, very proud of what they are doing in that area. But you look at the streets of Santa Cruz County, and the city of Santa Cruz in particular, and downtown, and we see people with these symptoms. Now, I've lived in here since 1970, and I was kind of a mall rat as a kid, and it was a real different environment back then. We had beds at Dominican Hospital in the 70s, and they started the neuropsychiatric service on Emmeline Street. There were, El Camino started our program in 1961 for inpatient services when we built the hospital. We had 36 beds at that time too. All the regional hospitals had psychiatric beds, it seemed, right? Everybody did. And that came, people think that came from John F. Kennedy signed the Community Mental Health Act, but actually California was the leader in mental health care. In 1957, this is why I talk fast, so bear with me. 1957, passed the Short-Doyle Act, and the Short-Doyle Act was, and by the way, talk about bipartisanship, sponsored by a Democrat, by Republicans, signed by a Republican governor. You know, there was great, and they wanted to take on this issue of state hospitals and the communities sending people away, and not being, in state hospital bed, the population was very, very high in this country and in this state. And so the thought was, let's treat them locally. And so you read this act, and it's impressive to read the 1957, what they wrote. I mean, you guys would be very proud of the people who were running our government at that time. So some example, maybe a little emotional, I'll get it, just give me a second. So they did a great job. And what they did is they called it the Community Mental Health Act. And 6 years later, and by the way, in 1961, El Camino opened our hospital. This was before John F. Kennedy signed the act. A lot of other hospitals did too. The idea was get them out of the state and bring them locally and treat them in the hospitals locally and integrate them in the community. John F. Kennedy in 1963 signed the Community Mental Health Act at the federal level, and I believe, I don't have tremendous research on this, I'm a nerd around mental health stuff, so I've got some more research to do. But that was, I believe, very much based on what we were doing in California, because we were doing amazing things. And that allowed funding streams from the federal level to support local mental health services in the community level. And ironically, that was the last act he signed as a legislator, legislative act he signed as president, before he was shot by somebody who, right, had a serious mental health condition. You read about his history, and that goes back to when he was a young man and did not get the care that he should have got. Right, so how ironic and horrible and tragic it was. But John F. Kennedy, through his own family history and background, had an understanding and a value of community mental health. So regionally, we had beds all over the place. I mentioned over the hill, San Jose Hospital. Good Samaritan Hospital still has a few beds. El Camino Hospital. Name a hospital over there, they had beds. They all did. Seton Hospital, all this, and almost all have closed through the years. And you know, how do we go from a system where we had lots of psychiatric beds, and when you have psychiatric beds like that, and there's a community focused on treating people with significant symptoms, you know, so the behaviors we're seeing in Santa Cruz County, and I can speak to this because I lived in the county since I was 10 years old, those people were picked up, they were taken to the hospital, and they were kept until they got better enough to release them back in the community. It was not what we're seeing today. That was not the situation. I know, I worked in those hospitals, I worked at Dominican, started in 1983, and it was a different system of care then than we have today. It's a different approach. So I'd like to say that there's nobody's fault. There's not a person you point to and say, you know, you messed up, you did this. There were unintended consequences to very good intentioned acts. And on this hospital side, We had there's a couple of nerdy things I'm going to talk about. One is deregulation occurred of hospitals. It used to be you had to have a certificate of need. You know, if you were going to open up and so Dominican Hospital opened up their unit in 1983 because they wanted to open up a neuro unit and add beds. And so the county said, that's fine, very good, we'll give you that certificate of need, but you'll also have to build a mental health unit. That's what it was like back then. And all the hospitals understood that psychiatric conditions are part of the health care problem. They understood that back then. Maybe the places were a little unique. You know, maybe they medicated people too much. I'm not saying it was the greatest treatment ever, but it was treatment local in the community. That's the way the system was designed from 1957. Okay, so what happened? Deregulation happened, and hospitals weren't making any money on their psychiatric services, but they were making money on their MRIs or their CAT scans or this or that or the other thing because it was limited. The effort was to limit the competition in healthcare, right? It was not because you understood that hospitals were providing services that were underpaid, right? And so a hospital understood you have to treat everybody, and you have certificate of need because that's the way we can keep our business going. You eliminate the certificate of need, now you have competition, you've got for profit. Prices go down in that, right? Because competition brings down prices, makes it a little cheaper for the government to pay, etc. But again, unintended consequences, we can't afford that psychiatric line anymore. We can't do it. We don't have the subsidy from the other services to support psychiatry. So they started closing their beds, and they were encouraged to close their beds by the hospital associations because they were too expensive to operate when you needed to cut your costs in those things that also made money. So that was a contributing factor. I've got a slide I show where I show, because I ran across it, they were trying to dump some stuff. They said, you know, Michael, we're going to dump a bunch of old stuff from your hospital from years and years ago. I first said dump it, and I went, well, let me go down there and see what they got. I found the most amazing thing. I found what the prices were for services in 1973 at El Camino Hospital, what an inpatient bed cost, what group psychotherapy cost, etc. And I was just fascinated by it because it was pennies on the dollar. And so what I did is I took that 1973 thing. I did a presentation on this at a symposium. And then I took the 2013, which I guess when I must do the presentation, and I showed what the inflation rate was over those years, right? So what would those services cost? What was $1 then versus $1 now? And then I showed the price and cost of services. Well, guess what? The price of hospital services is way up here, and inflation would have it about here. So, and why did that happen? Well, one thing that happened, who was working in healthcare? Typically, women. And women were making less money than men were, and they were working professional jobs, and they weren't getting paid very much. You went into it to be a nurse. You didn't go into it to make a living. You went into it because you know, you had a calling and all that stuff, right? Well, that wasn't acceptable anymore, and it shouldn't be, right? It's right. You should make a living wage. You should make a good wage. But that drove up the cost of care. All the regulations, all the building standards, on and on, lawyers, risk management, all that stuff layers on. You know, I went to do a talk before our IT group a little while ago, and the whole room, at least twice the size, filled, standing room only, with people who worked at our hospital in information technology. And I looked at that and said, well, you know, when I started in hospital work, information technology with a couple of geeks in the basement. That was it, right? No, all this stuff, it's all required. It's not, you know, blowing money. That's what healthcare requires now, but all of that comes with a cost. And so the cost of care has so dramatically risen. Now what happened to the revenues, right? The revenues did not keep pace with the cost for the hospitals to do this, and so money was spreading out the door. Couldn't keep these services going, start closing down the hospitals. Okay, so who provides the care now for these people, right? So we had a thing called for-profit hospitals sprang up because they could provide the care much cheaper than a hospital could. They only did behavioral health, they weren't unionized, on and on. They kept people, a few of them, and it's not telling tales out of school, a few really bad players in those days. So they kept people till their lifetime benefits ran out. Do you guys remember lifetime benefits? And so they kept them, the lifetime benefits went out, boom, discharge. Everybody stayed 30 days. Well, why does everybody stay 30 days? Well, that's when their insurance runs out. And so what happened? Well, you can't have that, right? It became too expensive for the insurance companies to provide care, so they invented a thing called, managed care. Let's farm it out to a place that does behavioral health managed care. And that's a for-profit enterprise. Here's their business model. You give me $1 because you don't want to pay for, you know, I'll give you $1 because if it costs us $1.50, I'll give you $1. Would you please take care of this problem for us? Treat all those people. Okay, that's good savings fee. I understand the model. But I'm going to take 20% of that $1, and I'm going to put 80% to treatment, and I'm probably being generous. It may be worse than that. Yeah. They're not telling us. So what did I do? I just took 20% of the healthcare dollar and out of the system. So now we only have 80 cents on the dollar available for treatment. That's the managed care model, right? It's a for-profit model. They make their money on the difference between, they're incentivized not to provide care, right? What are they incentivized to do? They're incentivized to not provide care. That's what they're incentivized to do. So now we have patients that used to stay a month or 2 months with significant symptoms, where they're screaming in the streets. That doesn't get better in 5 to 7 days, folks. Maybe it calms down because they got some sleep, some pills, medication, whatever. Look, I mean, they're back on the street. It is a quick cycle back to those symptoms. That's how it is. That's the mental health condition, right? That's how it is. It needs a longer treatment, it needs stabilization, and it needs a whole system of care after it. But that's not, the metrics we use are, with a managed care company, they we don't play the game very much. They know me well, but, and it's never personal, I understand. But they'll say, well, Michael, here's the metrics, we're this managed care company, and your report card isn't doing too good over there at El Camino. I said, well, report card? What's your report card? How am I doing? History or English? I know I got some deficits, Although I am the principal of the Aspire program, by the way, as I'm Principal Michael Fitzgerald, which is make my principals at school laugh their heads off if they saw. I was always in the principal's office, so. But anyway, so what they do is they say, okay, here's the metrics. You keep people too long. We want you down to 5 days, 5-day hospitalization average. And your readmission rate was really good. They said you're doing really good on the readmission rate. Now, we did really good on the readmission rate. Guess why? We kept people longer than 5 days. That's why we did better on readmission rates. Sometimes we kept people a lot longer than 5 days because that's what it took to get better, right? When you're seriously mentally ill, you're living in tatters on the street, you're in and out of jail, you're eating garbage cans, 5-day hospitalization ain't going to do it. Ain't going to do it. So anyway, so that was our report card information. We didn't get a really good grade, I guess. So anyway, but I told them, well, they want to, hey, you can make more money. We'll pay you more if you do this. No, we're not doing that. Not doing that. Not doing that game. I told them what I want to see on the report card is what's the family engagement? Did the families come to a meeting with the doctor and the social worker? That should be on the report card, right?
Yay.
Right. So yeah. So what's the patient's buy-in to recovery? Right? Did you discharge them to the level of care they needed? So. It'll pass. Right? So that's not the metrics they're using because the incentives don't drive those metrics. So when we talk about how the mental health system exists today, that when you walk downtown Santa Cruz and you see the situation we got, that's the background, folks. That's how it got there. Nobody wanted this to happen. Nobody in the mental health world, nobody at the state level, federal level, wanted to see the system of care that currently we have. But here's what we have. There's the law of unintended consequences. Sometimes it's all you're left with in the end. And again, we're doing some great stuff at the community level. One other thing that happened that was very significant, kind of the coup de grace in some ways, was the realignment and capitation system. So State Department of Health managing Medi-Cal, right? So when I started in mental health work at the hospital level, the county took patients out of jail and they brought them to the hospital. One coming in, and here comes the jail, and they're bringing you the patient. And we would keep people longer, et cetera, because we just built the state, Medi-Cal. We just built the state, paid the bill, right? Because they needed the services. You had to document, you had to show it, but the state paid the bill. But the state is spending a lot of money on mental health services in California, and they made the decision, working with local communities, that what we'd like to do instead is decrease hospitalization costs because all the reasons I mentioned, it's getting more and more expensive. Doesn't cost the same as it did in 1961, even accounting for inflation. What can we do to get these costs down? Really good idea if you think about it. Hey, I got an idea. We'll give you the money, counties. We'll give you the monies that you have spent historically, and you manage it. We're going to do that because we know that you're going to build all these systems of care that's less expensive than hospitals. So guess what happened? Some great programs came to Santa Cruz, right, and all the other counties, and the beds started disappearing. Well, for a whole lot of people, that's great because they can access those care, and for a whole lot of people, they couldn't, right? Their symptoms were too severe. The beds closed down. When I started at the Dominican, there were 28 beds. We always had 32 patients. I don't know if any of you had clients and so forth at that time, but they were sleeping in a conference room. I'm sorry, we did, and we shipped them out of the county because we didn't have any more beds. But they got help, and we were incentivized to treat them because they weren't using other services. They weren't going to the jails and using services there. They weren't on the street disturbing people because the bills were being paid on the state level. There was no capitation to it. So I hear capitation, that's like, to me, not a nice word. Not a nice word because it's actually you're capping the dollars that you can spend. And now you have to figure out how to do it. So yeah, some good things happened with capitation realignment. Means the county's now controlled it. Now not only got the money, but they got to control how it spends. Capitation realignment, 1993, 1995. That's when I said, I'm out of here. I got to go work in the. I don't like my job anymore. I can't help people anymore because they're not helping in the moment, but we can't get them the services they need. I saw labeling come in, right? People who would normally be now they're system abusers and And, and worried well, I love that term, the worried well. Well, actually, when you're feeling suicidal, you're far more than worried and far less than well. But that was the term applied unless you had a serious mental health condition. They didn't want to provide services to that group anymore at the funding stream level, right? That's managed care company, they're worried well. Just, come on, have we really come to this? Again, no one designed it, but the incentives drove this process. All right, so jails, become much more commonly used. What's the largest mental institution in the United States? You guys know this. The educated audience, Carol, you didn't tell me. I'm not surprised. We do a lot of work with NAMI with Hill, and we have a great relationship in Santa Clara NAMI. So largest institution, mental institution in the United States, LA County Jail, followed by Cook County, followed by Rikers Island. That's where people are going with these conditions. And you read Peter Early's book, Crazy? It's a great book. I met him, talked to him, we had him speak at one of our symposiums, had dinner with him. And he's a great reporter of the Washington Post, and he just wrote about his son's experience and his experience with his son trying to get through mental health treatment. And that's the experience that people are having. And it's tragic, it's hard, we're better than this, we're better than this country. So, all right, so what are we doing? So, the hospital levels have been, this is where the Hospital Association doesn't like when I'm not singing a party line all the time. But the hospitals have stepped out of the mental health business, and they said, well, you take care of it, we can't afford it, let the counties do it. Let the private institutions do it. We're not going to take charge. Well, okay, so if you're a hospital for a community and you're not addressing or at least considering how can we work and how can we make it happen, maybe not have to provide beds, but maybe at least to be part of the community and build the service of care, this is the largest undermet healthcare need in the country. Mental health, can you think of anything that is less treated for a serious condition in this country than mental health? We would not do this for cancer, folks. We wouldn't do it for heart disease. But arguably this condition is, for many people, more devastating. They had a survey that said, would you rather have cancer or schizophrenia? Guess what went out? They'd rather have cancer than schizophrenia. That's what it's come to. So there's ways to turn around, but as you can see, you have to undo a lot of things, right? The profit incentives that are there, they don't want to give that up. How do you change that? They've got lobbyists, they've got, on and on and on. Powerful voices, dollars driving the decisions. Counties aren't necessarily going to want to give up their ability to control dollars. Why would they? They want to use these funds. They want to help people. But we went from a 28-bed unit that had 32 patients and a bunch more out of county to a 16-bed non-hospital private health, psychiatric health facility. Is there less people needing acute services in Santa Cruz County than there was 30, 40 years ago? Come on. Are they able, these very ill individuals, able to step into a peer housing on day one of their sickness when they're knocking on someone's door and threatening to kill them? No. That's a later down the road thing. You have to have these acute stabilization. At our groundbreaking ceremony, we had a wonderful woman talk, and she had her son, and she had talked to me ahead of time, got my number from the county mental health director of Santa Clara County, called me up one night when we had the planner, he said, I got him, he's in my car. This young man had been in the streets of San Francisco for 8 months, had SWAT teams called out for him, shout out one time, Santa Cruz police, in Santa Cruz where he was living. He had a knife, and this guy's like 6'5", and he had a knife, and he was threatening, and the police backed off. They did a wonderful intervention, and that could have gone a much different direction, folks, and they did that a couple times with this young man. So the parents are very, very thankful for the police, not so thankful for the mental health system. He was hospitalized for a few days at this place, a few days at this place. Every place she went, she was told, he didn't want to talk to you, so we can't give you any information at all. So they keep trying to figure out what happens, and he'd be discharged without any contact with them. What a nightmare. And this went on, and she's very articulate. She's a journalist, left her job to try to save her son. 8 months on the streets of San Francisco, got him to our hospital. We treated him 2 months. Insurance did not pay for 2 months. This man's care. Said, well, he doesn't need acute symptoms anymore. He's not threatening anybody. But he is not engaged. If we discharge him, he is back in San Francisco like that, because that's what he wants to do. He doesn't get it. And through working with him, gradually, we had just wonderful staff, engaged, played basketball with him, dribbled around, and he began to loosen up. His old self came back a bit. Medications were more effective. He became engaged. Went to a residential partnership we had with Momentum, was there, then came back to us for 6 weeks of outpatient in our thought disorder program. He's now an A student in film. So a good outcome. So that's the way mental health should work. We don't get to do it all the time that way, but that's the way it should work. But you have to have enough beds to make that happen. It doesn't mean that keep people in the hospital until their insurance runs out like we did before. You know, you have to have utilization review. You have to justify the expenditure of the healthcare dollar. But I can tell you, this man will cost much less to the system, to our world, to his family, every way, socially, economically. It makes a lot more sense. And this is not a liberal philosophy. This is the RAND Corporation. This is every study they've ever done shows that effective mental health treatment, spending the money saves money. I talked to the HR boss at Lowe's, and he runs their benefit program, Lowe's. And I was at a conference, innovations conference in Las Vegas, and he was talking. And so I said, so what about mental health parity, man? You got to provide all this mental health. Aren't you worried about the cost or how are you managing the cost? I just assumed he's an HR guy. They're self-funded, right? So they pay right themselves. They're self-insured. And you know what he told me? He said, more treatment. So he understood that if you treat people, it saves money because there's less use of emergency rooms, there's less use of, there's fewer healthcare conditions, there's less morbidity conditions, there's decreased rate for heart disease, every condition goes down. Goes down. So that was an economic decision. That was not a, God, we love our employees or anything else, although he does, you know, they're a good corporation. But that was an economic decision to spend the money on mental health. So what are we doing wrong? You know? So it's a challenge. I don't know that more money needs to necessarily flow in the system. A lot goes for infrastructure and bureaucracy, as I mentioned earlier. The room full of IT people, right? Well, the county has that too. You know, the system of care has gotten extremely expensive. We do want high-paid, quality staff. We attract fantastic staff at El Camino Hospital because we're unionized, and we pay as well as the ER pays, and they all in the same union, and I'm happy every time to see that labor cost because we have fantastic staff and they earn it. So it means better outcome for our patients. Anyway, I've taken much time already, so what I'd like to do is just any questions you have on the history of mental health or where treatment's going. How's it going? It's been a long day, sorry I've been up since very early, so I'm usually not this emotional. Usually I just once or twice, give me a moment, I'm good. This one took a little longer. I think because I'm before all the family members and friends, I know a bunch of you guys, and a number of people here have had people in our programs, and thank you for your compliments, for the way, you know, that just, you know, that nourishes me and our staff more than anything, is to see people getting better. So, anyway, Cheryl, sorry.
What plans does the California Hospital Association have to fix things?
All right, good question. Yeah, so I guess I'm supposed to talk about that too. So,
wait, there's more.
Repeat the question.
You know what? I'm sorry?
Repeat the question.
Okay, so what is the California Hospital Association doing to deal with mental health concerns? When I started as the chair of the Behavioral Health Center, that allowed me to be on the board of trustees. So I'm in there with all these major CEOs. You know, I mean, these guys make millions of dollars a year. I'm not kidding. Wow, make that much? I mean, and they're all in this very formal room. You know, very dark, very formal board trustee meeting 4 times a year. They all play golf. And beautiful play. I love those 5-star places they stay at. I feel like, well, I don't belong in this group, but here I am at the table with them. And so I didn't say much about mental health. I'd have to do a report every quarter, and it's just a consent agenda item. I don't address it. But the conversations would happen in the hallways during the breaks, you know. And they started saying, well, so what? The first thing was like, what's wrong with the counties? How come the counties aren't doing anything? The counties aren't doing anything. I said, well, there's a lot that hospitals can do. That would be my, you know. I mean, you can lay it on the counties, and I'll blame the counties, but where were the hospitals in this? This is where I go off the trail. Actually, the vice president for the group said, Michael, you kind of went over the top there a little bit. I was at the state NAMI conference that I spoke at because we got a California Treatment Award, which proudest award we have. You know, very proud of that award. So, what are hospitals doing? So, now over the last 3 years, the last time I went, they're going, you know what? Maybe we should do more ourselves because their ERs are crowded, their communities are demanding it. What are you doing for this largest unmet healthcare need in the country? What are you doing? And so now they're starting to get it. So the president of CHA, Dwayne Donner, he's buddies with Jerry Brown, same age, has been in healthcare. He was part of the thing that brought in Medicare in 1965, and this guy has been around. And he has put forth initiatives, and I've been working with him on that, and we'll do some work in my last year as past chair, which starts in January, to make this the focus of my last year with CHA executive role, to bring forward these initiatives. And these initiatives have to do with access, they have to do with healthcare delivery system, it has to do with funding streams and siloed funding sources. He gets it. And so we're going to work on these. We know that as a hospital representing these things, we're not going to get a whole lot of airplay because the community doesn't trust hospitals necessarily when it comes to mental health, right? Because you took your kid to the hospital, and what happened? they didn't get the help they needed, right? So we don't, those think, what, you know, you guys are, you know, we don't have the kudos at this point. Health Community was the exception to that, but by and large, hospitals have struggled with this, and there's other exceptions too. So, yeah, so what are we doing? We're gonna do that, and what we're gonna do, and I'm telling tales out of schools, it's not public announcement, so don't call the anywhere, but the California Endowment Fund, we're talking to them. California Healthcare, right? California,
Central Coast Alliance?
no, this is the big organization for California Endowment and the California Health Fund. Anyway, these are foundation, California Healthcare Foundation, which was formed when Blue Cross and Blue Shield broke apart and went public. They had to give all this money to form this foundation, because as a non-for-profit, if you go profit, you have to give all this money back that you would have normally paid before. So anyway, they went public and they gave all this money. We're engaging them and their policy leads and with NAMI. So one of our folks on the CHA is on the NAMI California and is the incoming president to the California NAMI. And so we're right there, right? We have an opportunity to meet with we got to all work together on this and hold your hospitals accountable. If their idea of working with mental health is to write a $5,000 check to NAMI and pose for a picture with the president, thank you for your money, we can certainly use it. Now what are you doing to address the largest healthcare need in the country and certainly in our county? Keep the pressure on, right? Demand it. Public has a lot more power than you probably realize. So that's what they're doing. We're starting this initiative process, and the CEOs are starting to get it. They're all talking now. I got last two things, speaking role, you know, it's actually kind of hard to get it. And Dwayne telling me, you need to speak, you need to speak. And so I just said it, just like I'm talking to you now. You know, we need to do more. We need to be in our communities.
You mentioned meeting a representative from Lowe's. You talk about being knowledgeable about County of Santa Cruz mental health officials, being a member of the community.
Yes.
You have an organization you belong to that is incredible. You have a lot of statistics. Has anyone brought key people like this together to have a closed door session with our 5 members of the Board of Supervisors to show them how they could save money with their policies? And closed doors that they aren't embarrassed. There's no finger pointing, but when you talk to elected officials about saving money, and it's from people who aren't the directors of mental health or employees of theirs, it can make them listen.
Yeah, so to that point, one of the things we're taking on with California Hospital Association, recognizing that what's going on here is what we call siloed funding. So criminal justice has their funding stream, mental health has their funding stream, and so sometimes doing the right thing for the patient is not the right thing for you financially.
Right.
It's a different funding stream. They're not capitated on the jail system, right? So if they're in jail, right, that's a different funding source, and it doesn't affect your county budget as much as the mental health. Now, Lowe's is a different deal. It's all together. It's one funding source. See my point? So you got to change the incentives to make that happen. You have to see the bigger picture. You have to bring people together. You need some regulations around it. And by God, we need state oversight, because that's gone. State Department of Health wasn't very functional to begin with after realignment and capitation. Counties controlled it, and then they just eliminated it. So who's in charge of the state watching over mental health services? Well, it's a lower level person within the Department of Health and Human Services. I introduced her at a recent symposium and was not impressed. I was impressed with her transparency, that she's kind of wondering what to do. Well, that's a little scary, folks, when you're charged with regulating the mental health services for the largest state in the country. Really challenging. There's a reason why California has 12% of the nation population and 22% of the nation's homeless, right? There's a reason for that.
About hospital care for youth.
Yes.
When parents call me and they want to know, my child needs to be hospitalized, what do we do?
Yeah.
And based on my own experience at Fremont with my child, I tell parents it's kind of a waste of time, because not only, it seems like they're all, that it's functioning separately in a little bubble.
Yeah.
And when you're done with your 5-day stay or whatever,
Goodbye.
you look at the psychiatrist or psychologist, whoever you're meeting with, and they say, well, see ya, go look for some programs. Why is that? Why is there more collaboration?
Yeah, so, you know, I represent Fremont Hospital in my role, you know, they're members of the association, so I won't pick on any particular hospital. I'll say that's endemic to the system, not Fremont Hospital, of course. But, okay, for that reason, where's the incentive, right? Do they have an incentive to spend a lot of time on the phone and do all this collaboration care? Where's the incentive for that, for them?
They don't even call
I can't defend it, I can't defend it, yeah.
People that can support the family.
But what if they got a, report card for that, instead of how little they kept the patient in the hospital? Wouldn't that be a better thing on that report card? Now they're incentivized to do it. That's what I'm talking about. We've got to change the incentives, and that will change the process. Does that answer your question, or?
I mean, you're validating it.
Yeah.
Are there people that, honestly speaking, are there people in this arena that are all screaming out saying, what can we do at the higher level? Like you, that are saying, this is really tragic, we need to
Yeah,
do something.
yes.
Are they just trying to keep their head above
Well, most of
water?
them are families and consumers, and they're not paid to do it, and it's, you know what I mean, it's more challenging.
Yeah.
That's why we want the California Endowment Fund and California Healthcare Foundation to do some of that stuff, because they can represent it better than I can as a hospital representative, which is the truth. But I can be at the table, and I'm at the federal level too. I was already started on their advisory thing for the Leadership Institute, which is all hospital systems in the country. I'll be on their advisory group to help direct that. So the whole system has to change to make this happen, but the incentive processes have to change. We're meeting with Sutter system, and I tell you, Sutter gets it. Especially, by the way, be proud of your Santa Cruz Sutter. They're driving the change for the whole Sutter system. They're saying this is not okay. What can we do better? So, I know they've gotten a lot of criticism for not doing it, and they've heard that criticism. Speak up with the Sutter people. Speak up everywhere. And so we're meeting with Sutter tomorrow. I got a meeting early in the morning with Stanford, and they're bringing their whole adult services department heads, chief of psychiatry, business people, because I presented them with a paper saying we can build a system for collaboration. And it was kind of arrogant, called it a white paper, set it out. I'm thinking, what the hell is this guy? But you know what? They want to hear it, and we're going to talk about building a collaborative model with Stanford. What does Stanford got? Research. What do they got? Residents. What do they got? Funding streams for mental health. What does Sutter have? Primary care, right? 5,000 primary care doctors in Banff, right? And 1 million lives. They've got that. Co-located services. What does El Camino bring? Programs. Let's get to what's the competition about? Why are we not talking? Let's make this. We all got to come together. That's what it's about, and that's what drives me every day to do what I do. And there's people who do want to help and want to do it. It's just hard. It's hard work because the incentives don't do it. The incentives argue you not to provide mental health care. All the incentives are built not to provide the care. That we got to change all that, and make the incentives more than just our heart. We have to make it so that the business leaders who are removed from that heart of the psychometric emergency nurse that I was get it, right? And they'll get it through financial rewards. And there's some other questions.
I was going to ask, I hear you say like holding hospitals accountable and incentives and things like that. What's something that actual community members and like people can do, like personally do, to help change those things? Obviously, a lot of things need to be changed. Yes. But what can we do if I'm not like an elected official and all that?
Well, NAMI has enormous support of the enormous reputation because of the great stuff over the years. I've watched this grow as an organization in my career. And because you're not making any money on this deal, right? Oh, and I do want to throw out there, because I picked on everybody else, including the hospitals I represent, NAMI's got to be careful too, because there will be some financial incentives for them also. Some NAMIs have pretty big contracts with their counties, and so I was kind of shocked at a meeting one time where I heard a director of a county system say, oh, the police, they bring these people to us, they're just trying to clean up their streets, they don't really need. And I mean, I was shocked that she would say this. I think it was a moment of weakness. I know her; she's better than that. But the NAMI person didn't say anything. I called her up and said, I didn't want to say anything. I mean, and she's a wonderful person, but they have, I said, they have they have to think business decisions when they're communicating with people. So I don't know if you guys have a contract with the county for any services. If you do, you have to know that and maybe look at your corporate structure so that never influences your advocacy. And your advocacy is very strong. If you guys say, we want the chief of police to come here and address our group, that chief of police will be here, right? I came to a meeting where our Danner came when he was alive because you guys wanted to talk to him about why mental health people are being criminalized when they need treatment. I remember that meeting many, many years ago. I was there. So, yeah, that's it. You guys have strength. You have strength because you have numbers, and you don't have an agenda except to change the system for the better. So use your voices. You have a stronger voice than you know.
What about the parity? It seems like that should be a very sudden, benefit.
Yeah, okay, so here's what parity's at. It's worse on the public side than the private side, but it's bad on the private side. Okay, so now managed care companies, because they used to say, well, we're not going to cover your psychiatric, or I'll tell you what, you can come to the hospital, we'll cover you for $300 for your entire stay. I mean, and everything else out of pocket. I mean, come on, that was the mental health system before parity, right? So now we have parity. God love parity. Patrick Kennedy carried it. In the Senate, I like to tell a story. Pete Domenici right? Budget hawk. You wanna go to Republican with a budget hawk? Nobody had a better reputation for cutting the budget than Pete Domenici. And he and Paul Wellstone had if you talk to Pete Domenici, you call it the Domenici-Wellstone Act. Talk to Wellstone, they'll call it the Wellstone-Domenici Act, right? They're proud of that legislation. That was mental health parity. Why? Pete Domenici has a daughter with schizophrenia. Okay, so
Yeah.
that impacted.
Hit home.
You bet, it hit home. And he, God bless him, he made a major change. So I'm off, I was tracking. So parity, okay, so parity has problems because now they have to cover your psychiatry visit, right? So finding a psychiatrist in the Silicon Valley who's gonna take what UBH is gonna pay. When you have millionaires, you can't cross the street without hitting a millionaire. They don't have to take that insurance, that's UBH, right? So if you're somebody who doesn't make $1 million and you have United Healthcare and you have UBH as your payer, good luck finding a psychiatrist who's gonna take that insurance. So they have parity, yeah, we'll cover you. Yeah, you get covered, man. Yeah, go find a psychiatrist who's contracted, and they'll show you the list, and they're called phantom panels. Sometimes they're called death panels because they're literally dead. The psychiatrist. I say, I'll look at it a year later. I'll say, he's just as dead as he was a year ago. Maybe there's some miracle cure that he'll come back and be on your panel, but I'm not wagering on it because he wasn't. He's dead a while. So we call them phantom panels. And if you do call them up, and our chief psychiatrist is on the panel for these companies, and I try to have a meeting with him, and the phone kept ringing. I said, pick it up. It said, my practice is currently closed to new patients. No. So I wanted to say, excuse me, my class. I'm listening to this over and over again. I'm going, what the heck? And they would say things, and they'd say, yeah, and they always say in the last one they called, that's the last hope, right? So they can't find. So what do? You know how many calls I get from friends and people I know because they know I'm in the business? Tell me, can you find a good psychiatrist? I'm going to have to pay out of pocket. I can't find anybody. And these are families who are struggling.
Yeah.
They're struggling, and they have to pay for something they got an insurance card in their pocket. Again, cancer, heart disease, orthopedic injuries. Tell me another field where this happens, where you have to beg, where you have to pay out of pocket. It's not parity. And the public side, horror story, Warren, family called me, said, okay, we have Medi-Cal, but it's not severe. They got moderate severe. This whole process, even they admit it's nutty. It's got to change. So they were told, okay, we can pay for a psychiatrist, but you're going to have to go find one and get them to agree to contract with us, and then we'll cover it. If you can talk one into contract. What the hell? Okay, so now I'm an insurance broker so that I can get my kid help? I'm not kidding you. This is a true story.
Yeah. And then even after that, you fight them for 2 years to get them to pay the parity they're supposed to pay.
Yeah, so that's not parity. It's parity because it's covered, but it's not funded. Then that's really not parity, is it? NAMI today saw an email come across from, I guess, National NAMI, a press release saying it ain't parity, guys. And they've done some work on that. Kudos NAMI once again. So you guys are doing work, you're exposing this kind of stuff. And lawmakers, by the way, powerful voice at the Sacramento level, NAMI, and that's why hospital associates say, we gotta work with these guys, we gotta work with these guys. And we gotta get them to see that hospitals really do, and we gotta build, you can't just say we gotta invest, put the money where the mouth is, and then you'll get the support from NAMI. We certainly found that true in Santa Clara County. They're just wonderful, and we work very close together. Mentors on discharge, all that. They're on the unit all the time, and they do support groups there in our conference rooms. We're very integrated with NAMI in Santa Clara County. A question?
I'm just wondering if you could speak to your opinions on AB 3632, is that right?
3632?
Yeah, and
Child
just,
bill?
and just how public schools are now being taking on more costs.
Yeah, all right, so good question. So follow the money. So we passed an initiative in California, Prop 98. I am really a nerd, I'm embarrassing myself. But anyway, so they would fund, schools get so much percentage of every dollar in taxes, state law, right? Well, mental health services, the money's gotta come from somewhere. So they got together and they said, well, we're gonna make the schools responsible to provide mental health care. Like, actually pretty clever answer came up with that. So that's where the 3632, and it's to the degree that it affects their education, right? So it's kind of weird because schools, how are they gonna do mental health care? Who are they going to do it with? And so it's just, they hire a lot of interns, and that's kind of an invalidation at times. Look, I love interns because we train them and you need a new future workforce. But when you're working with a kid with that's the difference. And if you provide those social supports to that kid who's graduated from the foster care system, right, without a family, and they're 18, boom, they're gone. What if you did all this stuff, starting at age 16 or 15, all the things you need to do so that person doesn't end up, lining up the hot rails down by the levee, He's got another thing to do. They got an opportunity, got job support, education, all that stuff. We're not doing that. We're not paying for that stuff. We used to. And I got my career started with Department of Rehabilitation dollars, So a very basic level, but the support was there for that. And a lot of the things and programs that were run by them, not nearly funded as well, not around. So anyway, but there's still some great programs out there, being critical, but that's what I would push for, is more social support dollars, so they're not, thrown back on the street with nothing, and more longer hospitalization stays, so we can truly stabilize that person and get them into the services they can now benefit from. That's what I would do. Yeah. All right. Let me know when we're out of time, I'll just keep talking. That's the other thing, I talk forever, so. All right.
What about Laura's law?
Yeah.
I understand that it's a state law that's passed, but each county has to pass their own participation in this?
Correct. So every law that we pass for mental health services in the state has to run through the County Mental Health Directors Association, and they don't support everything. So Laura's law, the compromise there was, you guys know Laura's law, how it came, and it actually a lot of nine heads. So what it is, it would mandate outpatient care. So it would say you have to get treatment. When you've been threatened to kill people, and, it's not okay, man. You've got to see a doctor, you've got to get treatment, you've got to do these things. So how do you make that involuntary? So the thing is, it's really not involuntary. I'll talk about it in a minute. So they agreed, the county mental health directors finally agreed, because the legislators getting a lot of pressure to do something. And so they agreed to Laura's law, but only if it was voluntary. So only one county did it, Nevada County, which is where Laura lived and was murdered, who was a mental health care worker killed by a mental health patient. And then LA County did some stuff, and they do it different ways, and now there's kind of a mushroom. You know why? Because people like you are saying, come on, man, downtown ain't what it used to be. I can't, this is what's happened to our towns and cities everywhere, not just Santa Cruz. Santa Cruz has it pretty bad. But I took a trip to Red Bluff, where I was born, and Central California, and it's everywhere, man. Small towns everywhere. You see it everywhere. And our communities, you used to need to use the bathroom. Remember, you needed a bathroom, you go to a place, use a bathroom. Now you got codes and keys, and you can't use a bathroom anymore. Why? Because somebody OD'd in there and died, and somebody else did, our world has changed because of this, man. And we got to get this treated. So Laura's law, because I'm wondering, Laura's law, what that did was do this mandated outpatient. If you read Laura's law, a lot of the advocacy agencies were against it. It's actually a commitment to treat you, because they can't put you back in the hospital because you didn't take your medication or didn't go to a group. They can't do that. Laura's law doesn't allow for that. What it does say, it allows the people who write or eligible to write 5150s can now come and assess you and make sure that you're not threatening to kill people, not threatening to blow up your neighbor's car. And you know what? That makes common sense to me, right? When you've done something like that, that's a pretty good idea to have somebody checking in on you and make sure that you're safe. So that's all Laura's law does. It mandates that you go to treatment. If you don't go to treatment, okay, but now we're going to see whether or not you're still safe. And we'll take you to the hospital if you're not. That's Laura's law. So I think it's a great law. I understand the advocates were against it, but when they talk about why they're against it, which you read, is not, in fact, what Laura's law is. There's a lot of misinformation about it. Counties don't, for the most part, don't like it because it mandates them to do all this treatment, and again, they want to be able to control the dollars as they see fit. I understand that. Nobody wants you to tell your grocery money, you got to spend this much on veggies or anything else, right? They don't want to be told how to spend their healthcare dollar. They want to use it what they see in their own community. So that's their objection to Laura's law. So that's it. I'm a supporter.
Could we, as NAMI, go down to the Board of Supervisors and get on the agenda and say,
yes,
we want
yes.
this,
That's
and
what
we
they've
want
done in
this
other
for our
communities.
county?
That's what they've done in other communities, you bet.
Yeah.
They have, and you'll get a lot of double talk. You'll get the county say, well, we're looking at it, but we're doing this other wonderful thing. And they'll
Could
and they'll
keep the
invite you, and by the way,
pressure
do you
on.
want some money for your program? I mean, no, I'm serious. This is what's happening.
Yeah.
You got to do it. Get your group together, your board together. So we're going to support this. Here's what we need to do to support it, and then do those things. And that's what's happened in other communities, and that's how they got the Laura's law passed. You guys have a powerful voice because you're not seen as an incentive. Your incentive is to make it, your loved ones and the system better. That's your incentive. Who's going to help them argue that? You have a lot. You can get a state legislator in here. You can get all kinds of people because you guys carry the credo. I can tell you that because we've had some disagreements on involuntary, ER things and stuff like that. State NAMI did not support the bill we tried to pass, the hospital system, AB 1300, did not pass because in large part, county mental health directors didn't like it, NAMI didn't like it, it broke down, it wasn't good. So we got a lot of repair work to do on that. I think it was a good law, but others disagreed. They were worried that we didn't have, they were worried AB 1300, this is where we're going to make it more possible for ER doctors, for example, to write 5150s, because a lot of counties won't let them. My God, police officer over here can write one, but a freaking physician with an ER can't write one because they didn't want people hospitalized necessarily. I don't know. So we wanted to change some of that stuff, but we didn't have any trust with NAMI because they go, you guys don't, all you do is dump my patient, my loved one. That's the reputation hospitals have. We got a lot of repair work to do there before we can make more effect, but you guys are good to go on this stuff, and you can put a lot of pressure to bear. The other thing I want to say, Carol, is that there's gonna be something about this case with Sean, right? There's gonna be some kind of commission, there's gonna be some kind of study. It's gonna happen because you want some money for your program. I mean, no, this is serious. This is what's happening.
Yeah.
You got to do it, get your group together, your board together. We're gonna support this. Here's what we need to do to support it, and then do those things. And that's what's happened in other communities, and that's how they've gotten local law passed. You guys have a powerful voice because you're not seen as an incentive. Your incentive is to make it, your loved ones and the system better. That's your incentive. Who's the hell's gonna argue that? You have a lot. You can get a state legislator in here. You can get all kinds of people because you guys carry the credo. I can tell you that because we've had some disagreements in involuntary, ER things and stuff like that. State NAMI did not support the bill we tried to pass the hospital, AB 1300. Did not pass because in large part, the county health director didn't like it, NAMI didn't like it. It broke down, wasn't good. So we got a lot of repair work to do on that. I think it was good law, but others disagreed. They were worried that we didn't have, they were worried AB 1300, this is where we're gonna make it more possible for ER doctors, for example, write 5150s, because a lot of counties won't let them. My God, a police officer over here can write one, but a freaking physician working ER can't write one because they didn't want people hospitalized necessarily. I don't know, so we wanted to change some of that stuff, but we didn't have any trust with NAMI because they go, you guys don't, all you do is dump my loved one. That's the reputation hospitals have. We got a lot of repair work to do there before we can make more effect, but you guys are good to go on this stuff, and you can put a lot of pressure to bear. The other thing I want to say, Carol, is that there's going to be something about this case with Sean, right? There's going to be some kind of commission, there'll be some kind of study. It's got to happen because before I started, I was over in this room interviewing with a Sentinel writer who's all over this, and you guys are very vocal about it, candlelight vigil, et cetera. Here's my warning. Don't let the fox guard the hen house on this. They'll say, we're going to start this commission, and the county mental health director is going to appoint, and just, wait a minute. They're defending this current system. We need an independent, this is what happened in Santa Clara County, probably read about it, jail inmate, serious mental illness, killed by guards. Those guards are now in prison, charged with murder, right? So what did Santa Clara County do? They're horrified by it. Did they have, the sheriff run a commission, blah, blah? No, they hired a judge who was a very strong mental health advocate. We know her because she does a lot of work with a minimum key partner of ours for residential care. And they had an independent body, and they were harsh, man. They were harsh on the jail. They were harsh on mental health. And guess what's happening? Lots of change is now happening around that. A lot of funding going to jail diversion programs, crisis management services, different ways, and get those mental health patients more and more out of prison. That's the power of an independent, so keep that. Don't allow them to run how this discussion goes. Make sure that the people that are representing are people who are about the community. That's my warning on that.
Good one.
Okay. Any other, I've taken a lot of your time. Thank you. I have some cards on the back table, and just if you run out of cards, just help me in the hospital, Mike Fitzgerald, and it may take a little while to get back, to you, a day or two. Sometimes my email and voicemail backs up, but I will get back to you, promise. And family issues, anything, call me. We'll help. Hospital care will help. That's our mission. We're not a private hospital, and we're able to do all this stuff because we have a wonderful, wonderful board. They just love it. Wow.